So I'm here to introduce a well-renowned professor at the University of KwaZulu-Natal in South Africa, Durban, Professor Moshabela, who is also the Vice Chancellor of Research and Innovation at that university. Ladies and gentlemen, please put your hands together. Karibu, Professor.
Wow. Good morning. It is such a pleasure for me to be here. I bring you warm greetings from the coast of KwaZulu-Natal and the Kingdom of Zulu in South Africa. We are very much honored to be invited to share a keynote today as members of Arise. And I hope that I will achieve what I'm hoping to do today, which is really to put some spotlight on this issue of implementation science. I rise on the protocols that have been presented before me and all protocols observed. I do want to acknowledge the Ministry of Health. I do want to acknowledge the board of AAPH, the leaders of AAPH, the leaders of the different universities here. It's such wonderful to see you, my friend Bruno, as well. We last met in KwaZulu-Natal last year. Colleagues, those of us who have a duty to implement programs on the ground, for many years, for a long time, we've had a tough time because we did not really have the science that was helping to guide us in terms of implementation. We receive funding from donors. We receive evidence from those who are doing clinical trials and other studies that produce evidence on the effectiveness of interventions or the efficacy of interventions. However, when these interventions come to us, we have to figure it out in terms of how to make sure that those interventions get to the people that need them. In the past few years, we've had a young science that has been developing in terms of implementation science, which is still young. And we are still trying to understand it. We are still trying to optimize it. We have partnered with a number of other colleagues from different parts of the world to try and figure out implementation science. And I just want to share with you in terms of my thoughts on how we can leverage this to improve the health of adolescents. Together with colleagues at WashU University in St. Louis and others in the US and across the world, we have sort of been working with this definition of what implementation science is. And believe me, there is no clear consensus, but generally, this is the science that gives us methods that can promote the systematic uptake of research findings and other evidence-based practices into routine practice. We generally call this translating research into practice. But really, it includes the study of the influencing factors for those who are the professionals and the institutions or organizations that are tasked with this duty. If there's anything that you should take from my talk today, is that implementation science is really the study of behavior of patients, behavior of providers, behavior of people that are our partners, behaviors in different ways. The science offers us, those who have to implement on the ground, a systematic approach where they can study what we call determinants, or others can call them drivers, processes or strategies that are required to successfully ensure the uptake of these scientific discoveries. It's really a bridge between the part where we do research to generate knowledge and also what happens in programs in terms of implementation activities. We often refer to it as the how-to science. Just to give you a perspective, it is a science that draws on many fields. Many of you would be familiar with quality improvement interventions, especially in maternal health, PMTCT. We've used quality improvement a lot. Institutions like IHI and others have done this work a lot. We also draw on dissemination research. Professor Rugajo indicated the importance of sharing knowledge, and we often do this within dissemination research, but we have to pull this together in order to make sure that effective communication accompanies our efforts to implement effective interventions. Generally, in public health, we would deal with what we call a triad, which is a common term we speak of in epidemiology, which is a combination of a disease, the agent, and the environment. But when we now translate this into programs, we will then define an intervention, and we will define the processes that have to be put in place, or a plan to implement the intervention and the outcomes that we want to achieve. Now, it is normally up to program implementers and managers to see to it that they achieve this. How they do that will then depend on their expertise and experience and resources that they have. In implementation science, what we are arguing for is the importance of unpacking the understanding of the context in which you work. And the understanding and knowledge of context in itself become an area of expertise that becomes necessary to successful implementation. An understanding of the different actors that are involved in this, be it policymakers, decision makers, implementers, patients, donors, and so forth. The understanding of what we call drivers or determinants. Some people refer to this as barriers and facilitators. Those things that are likely to create stumbling blocks, or those things that are likely to be success factors. We want to understand them and use them, leverage them as we implement. Likewise, with that understanding, we translate them into strategies, and I'll come back to that. This is besides what we normally do in terms of process and outcomes that we are used to. There are some frameworks that have been developed. Enola Proctor from WashU has developed this framework that we use as a starting point in understanding implementation. And really what's important here is that before you get to what we normally call health outcomes, which is really what we are all chasing, there are certain outcomes one needs to achieve. If you want to get to 5, you must first get to 4, you must get to 3, you must get to 2. You can't just go from 1 to 5. And we need processes that are put in place, or strategies that are put in place to make sure that we optimally achieve implementation outcomes, we achieve service outcomes before we even get to the health outcomes. They are the means for us to get there in that pathway of impact. There are other frameworks, as I told you, that behavior is very important to implementation, and this framework is called the COMBI framework, which really looks at capabilities that are there in the context in which implementation needs to happen, the opportunities that are there, the motivation, and a combination of which contribute to behavior. We study this in order to optimize implementation. We use this implementation research logic model that most people who are in program implementation will generally understand, that when you've defined your intervention, you must understand the determinants, you must use them to develop implementation strategies that are going to help you understand what we call mechanisms. Mechanisms are going to be the things that are going to achieve to translate strategies into outcomes. And I will mention that again shortly. But the starting point usually is in terms of the consolidated framework for implementation research. This is where we study facilitators and barriers. All these frameworks are the tools that we use to help those who are new to implementation science to navigate how to employ implementation science. And in terms of HPV, for example, if you want to introduce a vaccine, you can study the facilitators and the barriers. Use this to then inform how you design the implementation of the intervention. We know the vaccine already works. That is not the question. What we are focusing on is how to make sure that it gets into the arms. Now, the thing that really is important, and that is the biggest challenge in implementation science, is developing implementation strategies. And we don't really have an agreed upon definition of these implementation strategies, but I will try to describe them. We do this all the time. Even in the PDSA of quality improvement, we talk about ideation, we talk about these things we come up with. But we don't necessarily see them as a form of a science, and we don't necessarily approach them in a systematic manner that implementation science is actually calling for. And these are the methods and the techniques that we use to enhance the adoption, the implementation, and sustainment. And sustainment, of course, is the outcome of what we normally call sustainability, and the scale-up of a program or a practice. When you have designed a strategy, an implementation strategy, you need to be able to name it so that we know what it is. You need to be able to define it. You must specify who is going to implement it, the action that they need to implement, what the target is, specify the strategy that is used, the dose, how much of that strategy needs to be given. If you need to implement that strategy 3 times and you only implement it once, you're not going to achieve the outcome that you're hoping for. Then you also need to specify the implementation outcome. As I indicated, that we often neglect what is implementation outcomes because we so focus largely on health outcomes. But implementation outcomes are those things that we need to achieve, the intermediate outcomes that we need to achieve in order to get to health outcomes. And you need to provide justification as to why this. There is sort of the evidence behind the strategy needs to be specified. Now, for adolescent health, within ARISE, we emphasize the importance of conducting surveillance, which is also why we work in demographic health surveillance science. We collect demographic and health data that help us to inform the need for interventions. So out of that, the information we have, we design interventions, and we have moved into a phase where we are using human-centered design. Some people will talk of people-centered design in order to do this. This is all for the purpose of designing an intervention. But what I'm proposing is that we also use implementation science to inform the implementation of these interventions. And of course, we are also moving into a place where for evaluation, we are looking into theory-driven evaluation that I'm sure you'll hear more about. And ARISE, of course, emphasizes the importance of need, design, performance, impact, value, and scale. And we use this idea of human-centered design that we've been talking about in the past few days. And in terms of theory-driven evaluation, we want to do experiments, quasi-experiments, and performance evaluation. What I'm now proposing is that we take the lessons that we have learned. For example, in Eastern and in Western Africa, we have noted that healthcare utilization amongst adolescents includes informal healthcare. It's not just formal healthcare, especially so in Western Africa. But oftentimes, we approach healthcare as if it's only dominated by formal healthcare. And here I'm showing you from the previous survey that we've done that if you were to ask adolescents in the past 12 months, have they been to healthcare, nearly 40% of them would have used formal healthcare, but a whole lot of them would have used other forms of care. You will also find that there's about 80% who actually need healthcare but don't access it. Now, this tells you that a lot of adolescents are not necessarily going to be found in health facilities. And if you really need to find them, you need to be able to go to communities, you need to go to schools, you need to go to other places, in addition to those that will present to health facilities. In fact, it's very interesting that with adolescents, most of their health needs are for prevention and health promotion, rather than to actually treat diseases. So we have to approach their health needs from that place of prevention, rather than predominantly curative approach as we normally do. These shifts in thinking across the world in terms of social determinants of health and what we call upstream factors that inform health outcomes have necessitated for colleagues to challenge the current WHO framework that we have for health, to say that it needs to include more social determinants of health, more societal partnerships, community organization, and the importance of household production of health instead of focusing on the supply side in health facilities. And hence, I'm emphasizing here that in our thinking around adolescents, we need to think beyond hospitals and primary healthcare clinics. We need to think communities. And in fact, for adolescents, let's also think virtual communities, not just physical communities as we know them. And of course, we have to take into account the different partners that we have to work with. And Bruno has enthusiastically shared with us how in Tanzania there is a strong collaboration between government and the universities, which has increased in the past few years as well, and that's very exciting. And I do want to emphasize here that we take context for granted. There are frameworks that we can use to study context, where we talk about inner context and outer context. And these are things that if you are committed to implementation science, we need to make sure that our implementers are trained and our implementation scientists are trained on how to study context, so that they can leverage the factors that they have control over in the context and the ones that they don't have control over in that context. Therefore, for ARISE, Professor Wafai, I'm proposing that within the framework of human-centered design and theory-driven evaluation that we have, let's include implementation science, where we are deliberate in studying actors, in studying context, in studying drivers, and designing strategies for implementation to support those people who have the duty to implement on the ground. And in summary, this is how I would phrase or present what I'm arguing to be a synopsis of what implementation science really brings to adolescent health. And we are still developing frameworks like mechanism mapping as a tool to really understand what is it about a particular strategy that actually works, that we can then use in order to achieve outcomes. And those are the mechanisms that at first we may not know, but as we study these strategies, we need to be able to demonstrate. That is the evidence that we are going to use for advocating why a certain strategy works and why it doesn't work. I want to finish off with an introduction to a program that has emerged out of a large collaboration that includes ARISE, that includes Heidelberg, which is called USINGA, and it's the Umlazi Surveillance Initiative to Nurture Grassroots Action. In South Africa, we've always had 3 demographic health and surveillance sites. We have added 4. And this is one of the new that has been added. This emerged out of the realization by government that having these communities that are studied annually and used as a way to test interventions is a crucial part of development, as we have demonstrated even during the COVID era. And for this reason, we have set up a new demographic and health surveillance site that will be contributing to the work of ARISE. It is people-centered, which is going to be intentional in adopting a human-centered approach. It is community-driven in terms of design, co-creation of interventions. It is also focusing on young people. As you can see in this community, predominantly we have young people. In the proposal, we argued for 14 to 40, but we will be arguing for lowering that age at the base to 10 years so that it can include the age categories for RIs. We are focusing intentionally on a youthful population, and this is one effort whereby we are creating an infrastructure that can be dedicated to the needs of the young people, adolescents, and other youth as a focus of this demographic surveillance site. And I want to finish off by thanking the contribution that has been made by ARISE and ARISE partners, particularly Professor Wafai, and also colleagues from Heidelberg, Till in particular, Guy Harling, Frank Tenser, and others who have assisted us in terms of building this infrastructure, and also colleagues from WashU, Elvin Gang, in terms of contributing to the implementation science knowledge that we have gained and we will continue to advance. Thank you very much.